late life psychosis, and here's why. Because most systems of care and most of the way that people think sort of makes an association that schizophrenia is an illness which afflicts younger people. This is because peak onset of schizophrenia-like illnesses occurs in late adolescence through the young adulthood. For women, it's a bit older range, but nonetheless, it's typically seen as a young adult or adolescent issue. The fact of the matter, however, is that schizophrenia-like symptoms can occur at any point in a lifespan, and there are a couple of other waves of risk that turn up. They've called these late onset and very late onset. So by consensus, we're talking about, we have 3 periods of risk. So we're going to talk about those with the idea of trying to get a handle on the demographics of some of this risk. We'd like to consider the extent to which the other schizophrenias, the later onset schizophrenias, might represent different illnesses or whether they're similar to the earlier onset versions. And then we'll, of course, consider whether later onset schizophrenias require any special kinds of treatments or assessments. So with the idea of trying to think about whether late or later onset schizophrenias are similar to or different from the earlier onset variety, I'm going to suggest that might miss a bigger and better question, which is that instead of asking, does schizophrenia that occurs in the 6th decade, is that the same illness as something that occurs in the 2nd decade? The bigger, better question is, to what extent is any schizophrenia a single illness? And I think if you've been hanging out with these discussions along the past year, you would know my answer, and if you don't, here it is. There's pretty good evidence right now in scientific literature, as I read it, to say that we could maybe not think so much about schizophrenia per se. We could even contemplate renaming this illness into something that might get a tad closer to etiology. So I'm going to suggest that based upon current evidence, we can say that there are dopamine psychoses, glutamate psychoses, inflammatory psychoses, psychoses of medical origin. I'm thinking about things like brain cysts in the temporal lobe, for example, or different kinds of seizure disorders, and none of the above. So I would suggest that schizophrenia is a etiologically heterogeneous disease. Then the question becomes, to what extent does later onset psychosis represent or overrepresent a certain kind of pathway within the family of pathways to schizophrenia-like symptoms? And just to slightly digress, I'm going to use the phrase throughout here sometimes, persistent idiopathic psychotic disorder, because with schizophrenia, what we mean when we say schizophrenia is that we're talking about a family of illnesses that are characterized by prominent psychosis as well as functional declines and can't be better explained by some other pathology. So I'm going to use tip disorder occasionally in this talk. Age of onset, it can happen anytime. We tend to think about the peak onset, the peak risk period being adolescence or young adulthood, but there are blips of risk that occur after the 4th decade or within the 4th decade and by the 6th decade. A consensus paper by Howard will be referenced several times in this talk, and it's an international consensus paper, and this group argued that we should call these 3 peaks early onset, late onset, and very late onset, with 40 and 60 being somewhat arbitrary cutoffs for the distinction between late and very late onset. So let's look at some risk factors, demographic risk factors. So for men, the period of peak risk is between 15 and 24. For women, there is the period of peak risk between 15 and 29. So the curve is a little bit wider for women. There's also a second peak that occurs at peri or early postmenopause between 45 to 50 or so years of age. And the In this late onset schizophrenia, the one that's 40 or so years old, there's a very decided overrepresentation of women in that group versus men, as opposed to the earlier onset risk, in which the risk is skewed men to women about a ratio of 1.4. So about 40% more males will get a schizophrenia diagnosis than in that period, whereas in the middle life, it's clearly women that are at greater risk. Not the case, though, for the very late onset in the 60 plus years old. That gender ratio pretty much disappears. So being female is a risk factor for the middle life psychosis, and in either late or very late, there are studies that suggest that having a premorbid paranoid or schizotypic personality would be a risk factor. Depression is a very strong risk factor in early psychosis. So a typical scenario, somebody struggling with depressive symptoms, then psychosis arrives, and then something that looks like schizophrenia develops. Depression still shows up as a bit of a signal in some of the studies for later onset, but it wanes in importance. And in later onset schizophrenia, deprivation syndromes, notably hearing loss as well as social engagement impairments, seem to be risk factors for developing schizophrenia-like syndromes in that age group. Another difference between later onset and earlier onset, on average, people with later onset schizophrenias are more pure positive symptoms, more hallucinations, more paranoia, not so much disorganization or negative features. Another thing about the later onset is it's more common to see hallucinations affecting multiple sensory modalities. So in early onset, typically it's auditory hallucination. In later onset, auditory is still probably the dominant pathway, but visual, tactile, and olfactory hallucinations can be more common in that group. So, so that's some of the small clinical differences between later onset and earlier one. How to go about assessing. So if somebody shows up to your clinic at the age of, say, 49 or 65, do you do anything different in trying to do the workup? And the answer is probably no, especially if you're doing the medical workup for early psychosis along the lines that would be recommended, which is to say, recognize that schizophrenia is a diagnosis of exclusion. You can't arrive at this diagnosis unless you actively ruled out a medical disease or other psychiatric syndrome that better accounts for the symptoms. So if you're doing it well in early psychosis, it's going to be the same later in life. But in the consensus paper by Howard, they actually make a clearer point that at this point, imaging of the brain is recommended. Most, to the extent any professional organization recommends it, they're pretty wishy-washy in their strength of recommendation for brain imaging in early psychosis. It's more direct in later onset psychosis that should be done. And since hearing loss and social deprivation are risk factors for psychosis in very late life, then hearing assessments, sensory assessments, and social assessments take on a higher level of importance as part of the assessment. Treatment for late and very late onset psychosis is assuming that there's no medical explanation for it. So if you're winding up with persistent idiopathic psychotic disorder, aka schizophrenia, then treatment looks similar, except for important points. Doses of medications tend to be less. Specifically, according to the Howard review group, doses that may be as low as 25 to 50% of standard dosing would be good doses for somebody with midlife schizophrenia syndrome. And if we go on to the elderly, then those doses can fall down to as low as 1/10 of standard doses. I will steal from my conclusion thunder and try to bring together a topic from the very early slides as well as a later one. I described how what we call schizophrenia probably we could more usefully describe as dopamine psychosis or glutamate psychosis or inflammatory psychosis or medical psychosis or none of the above psychosis. The reason why I'm proposing such distinctions is because for dopamine psychosis, there's a clear signal for hyperactivity of dopamine signaling, and that explains why antipsychotic drugs, which are primarily dopamine receptor blockers, are effective. So the fact that in later life schizophrenias, you find that the effective doses of dopamine blocking drugs are quite low would suggest the possibility that dopamine psychosis is predominant in this age group as opposed to inflammatory psychoses or psychoses of other origins from the earlier life group. So standard when I say standard, non-clozapine antipsychotics, whether first generation or second generation, are appropriate treatments for mid or late life psychosis. Doses typically can be lower, however. Another important consideration, again, think about the fact that in the second wave, in the late onset or the midlife psychosis, that is a psychosis that will arrive in the 40s or 50s, and in which women are overrepresented. The low-hanging fruit for hypothesis is that this reflects declining levels of estrogen associated with menopause or perimenopausal changes. And that finding dovetails with a significant body of literature, not really extremely large compared to where we would like it to be, but the signal is consistent that estrogens are neuroprotective and estrogens are probably psychosis protective. So having them go away is opens one up to the possibility of psychosis. And therefore, estrogen replacement therapies or estrogen augmenting strategies would be recommended for consideration and probably for actual use in the majority of women with midlife psychosis. So to summarize then, persistent psychosis not explained by other factors can occur at any point in the lifespan. By consensus, we recognize now early psychosis as being young adulthood, late psychosis as being around the 40s, and very late psychosis with being in the 60s. Medication doses can be much lower in later onset psychoses. Every patient with a new onset of schizophrenia-like symptoms deserves a thorough medical workup. And particularly for women in midlife psychosis, estrogen or the selective estrogen receptor modulator drug raloxifene should be strongly considered and probably utilized for individuals with that form of illness. So those are my remarks about